trying to get those stocked through the hospital for you. A lot of people, or a lot of departments, when they went with their monitors, we told them they had to start getting capnography. And they weren't due to buy new monitors, and their monitors didn't have the software. It was almost $3,000 to $4,000 to have the software or upgrade their monitors to have capnography. So a lot of departments did go to the handheld monitor until they were buying new monitors. So some of the indications for using capnography, obviously, ET tube verification. When you're using it, it's like this crystal ball into what's going on with our patient. You're working a code. You can automatically see, even if it's in the middle of a cycle, that you have return of spontaneous circulation. You can see that someone is getting very tired and they're about ready to go into respiratory failure. You can see how bad the bronchospasms are on an asthmatic. So you can, a lot of times, treat based off of what you're seeing. So when we look at it, you sit there and you think, gosh, how much can a square really tell me? As we go ahead and we, let's go to this one. So we're looking for this number right here, the end tidal. That is when we completely exhaled everything that we're going to exhale at that point in time. Air from deep down in the base of the lungs has finally been exhaled. That's what we're looking for is our number. As soon as we finish our exhalation, we stop. And so our waveform is going to drop right back down to 0. We start our inhalation process, and the reason it's 0 because when we're inhaling, nothing is coming out. We're not measuring any CO2. We start our exhalation process, and it does go up very rapidly, but you can see there's a slight slope because when we start our exhalation process, we have that 150 cc's of dead air space, and then up in the beginning, or up on the top of the lungs, as we go ahead and exhale, there's usually not as much CO2 until we get to the bases. So we start our exhalation period, and finally, at that point, that end tidal area, that's our final exhalation. Now, if we have numbers that are above 45, generally people are breathing way too slow. They're retaining a lot of the CO2. We see this number a lot of times when people have overdosed on like maybe heroin, and they're breathing 5-6 times a minute. If it's below the 35 mark, they're breathing way too fast. And this gets kind of confusing because in a way it's kind of backwards. But if they're breathing way too fast, they're blowing off the oxygen as well as the CO2. And they're not allowing a lot of time for gas exchange to actually occur. Patients who breathe slow are making themselves respiratory acidotic. The CO2 is an acid, whereas people who breathe fast are making themselves respiratory alkali. Now there's a couple different waveforms that are listed here. As you can see, we've got our patient intubated, we've got this waveform. What's nice about the end tidal is the immediate, when the patient stops breathing, we have a problem with the tube, it'll go back down to that baseline. So you're actually ventilating a patient, they're doing well, and all of a sudden, you're flatline. Take a look at your equipment. Did the ET tube become dislodged? Did my little adapter that measures the CO2 become? Do I have an obstructive tube? We use our pneumatic dope, displacement, obstruction, pneumothorax, or is your equipment problem to identify any loss of waveform? If we are actually having a good waveform and then we see a decrease in our end tidal CO2, do we have an ET tube that the pilot balloon is actually leaking on? Are we letting oxygen go and it's mixing with that end tidal CO2 to lower it? Again, too, could it be in the hypopharynx? Or is there an obstruction? We can also use our end tidal to say how good a CPR we are doing. When we are performing CPR on a patient, if we're doing good solid compressions, at least 100 a minute, ventilating, once every 6, once we got them intubated, our end tidal should be at about 20 to 22. At this point in time, we know the body can actually metabolize. We're seeing gas exchange actually occurring, which is a lot of times, like in Ohio, they had the one patient, they had end tidals, I think it was like 24, 25. They coded a guy for 90 minutes. And they got him back with very little neurological impairment because there was gas exchange occurring. They know that they were going to be able to do something. Compared to if you have less than 10. If you have an end tidal less than 10, call it. You verify depth. If the body, if you're giving it oxygen and you're doing circulation and there is no metabolism going on, those cells are dead. They're done. And if you're looking as a means to ask to withdraw resuscitative orders, let the docs know, hey, I've got an end tidal of 8. They're going to tell you, don't even bring them in. Call it right there. There's nothing that anybody can do. There is no documented cases ever of anybody having an end tidal less than 10 and having any type of return of spontaneous circulation. As you're going along and you're going about 20 as your end tidal, and all of a sudden it jumps up 60, 70, 80. That means that you might have a return of spontaneous circulation. So you're in your second round of compressions and you're doing really good CPR and you see this, it might be a great idea to ask, can someone check a pulse? Do we have a pulse? The reason we have this high spike is because now all the acid that had built up, all the CO2 that had built up in the body is now going to be exhaled out by the patient. So we see the big spike there. Another one is the shark fin. I'll be honest with you, I've seen the upward slope be a little bit more of an angle. Remember, asthmatics, COPD patients, they have no problem getting air in, it's getting air out. So as they're exhaling, they're pushing the air out. That's why you get that shark fin or that sharp, steep, delayed upstroke. You're seeing that, you know that there's bronchial constriction going on. You need to go ahead and give them a duoneb treatment, a albuterol, Atrovent, maybe even epi if it's bad enough to go ahead and try and bronchodilate these patients. Hypoventilation, blocks are long, you got a high level, they're not breathing fast enough, might want to go ahead and assist ventilations for these patients. Okay. Here also we see that they're metabolically alkalotic. We have a decrease in their metabolism. Okay. We know we can go ahead and, well, let's go here. If they're very short and it's very low, a lot of times we say hyperventilation. It's a 16-year-old girl that just broke up with her boyfriend. She's hyperventilating. We got to coach her down. We got to coach her to slow down her breathing. But we also might see low end tidals if a patient is metabolically acidotic. They're trying to go ahead and make themselves respiratory to balance and create homeostasis within the body again. Okay. There's another waveform and talk about here. If a patient has a little notch right on the top of that plateau, that a lot of times, if you've used your drug-assisted intubation and the patient starts to maybe wake up or the sedation's waking up, we see a little notch in there. We call it a notch plateau. Might be an indication to go ahead and give them a little bit more Versed. It also could be an indication of a pulmonary emboli if we see that little notch there. So those are a lot of the different types of waveforms. As far as verifying tube placement, we know that the end tidal does not rule out right main stem. So make sure you're still listening to lung sounds. Make sure you still go ahead and see the cords, the tube pass through the cords. Here, as we just talked about, you can see the sudden spike in the waveform. We know that we're doing adequate CPR and all of a sudden it goes up. Check for a return of spontaneous circulation for these patients. If it's less than 10, you might want to consider withdrawing resuscitative efforts. Other factors that are going to affect end tidal, causes for elevated end tidal, metabolism. Patients in pain, they're hyperthermia, they're maybe shivering. Those types of things where the body is increased metabolism will cause an increase in end tidal. Cause a decrease, hypothermia, metabolic acidosis within the body. Again, it's all about the body trying to compensate. We can also identify sepsis with our end tidal, and that's why kind of adding this into this month. A lot of different articles out there. You can read any of them as far as how end tidal can go ahead and identify sepsis pre-hospital. Early identification, early treatment does increase the chance of survival in these patients. Does anybody have any questions on their end tidal? Moving right along.
What would be some quiz questions?
There's a couple waveforms on there.
Yeah, like shark tooth.
Yeah, shark tooth for bronchial constriction. Can't remember what the other one is.
Probably that change maybe in the...
Yeah, return to spontaneous circulation, but I think it's multiple choice. No problem. All right, the EZIO. What are the two places for adults that we can do the EZIO?
Proximal humerus.
Yep, tibial tuberosity or proximal tibia, I'm sorry, and the proximal humerus. What is the preferred site for adult? The proximal humerus. You know what? Has anybody ever had a chance to go down to NIPSTA when they do the cadaver with the EZIO?
Let's not.
Sorry. Okay. There's a cadaver out there somewhere that they'll put the IO in both the tibial and the humerus, and they'll see how fast the fluids get to the heart. It is faster, obviously, in the humerus. I still haven't, personally myself, I haven't been won over in cardiac arrest using the head of the humerus. I get it, I've seen the statistics and everything like that, but to me there's just so much going on in this area during a code. That's why, like, you know, the leg, if you're the one that's responsible for putting the IV in and giving all the medications, you're kind of out of the way. But, you know, that's just personal preference. Pediatrics, the only place we use the IO is in the tibial area. Contraindications, if there's a fractured bone, if they've had joint replacement, if there's tumors, major edema, you know, those types of things. Oh, if they've had an IO in the last 48 hours, we definitely don't want to do this. So, in the past, we've had the 3 different type needles, and we called them, red was for peds, blue was adult, and the yellow was the big boy, or the bariatric needle. If you are doing the humeral IO, you should be using the yellow IO needle. The big thing is it doesn't matter what we used to call them. Now it's just small, medium, and large, making sure that you are measuring appropriately. So when we go ahead and we measure these, we put the needle through the skin and we push it till we hit the bone. We need to at least see this last black mark there on any of them, no matter which one we use. If we're not seeing that mark, that means that it's too small of an IO or too small of an IO needle. We won't be able to go ahead and be effective with it. So the other thing is that you want to at least, see this black mark here. When here, you want the skin to be somewhere in between this bottom mark and the top mark, somewhere in there. Push the needle in at a 90-degree angle, and then once you verify that you have that 5 millimeter mark visible, you can go ahead and start drilling and push forward, okay, until you feel like you're in. Now, we have to make sure we have that flush because we want to go ahead and provide the rapid flush to displace any bone fragments. I believe in this PowerPoint, and people are teaching, well, I can just hook up my lidocaine. If I'm doing this on a conscious patient, I'll just hook up my lidocaine right there and use that as my flush. The problem with that is that when we do our first flush, we do it rapidly to displace those bone fragments, but we don't push lidocaine in rapidly. Remember, lidocaine should be pushed in very slow, over 60 seconds. So I'd say don't use the lidocaine as a flush, but you know, other people do, I do know that. So for the adult or pediatric, put your finger at the tibial tuberosity, measure 2 finger widths down. Children, big thing to remember with them is that you avoid the growth plate. You don't want to put this in the growth plate at all. Do you guys have the adapters that actually or the stabilizers for the IOs? Those, yeah, those are an extra fee. I'm sure we don't restock those for you. But big thing is just remember to secure your IO. You know, most of the time it's in there pretty good, but you want to make sure that you're securing it. When you go ahead too, I was watching one of the students put one in the other day, and I still haven't figured out how people miss on this, but they were going ahead and he was using the pressure bag to insert fluids. And I was watching the fluid on the top of the leg just start to gather. Evidently, the needle was not the proper size. It was too small of a needle, so it didn't actually hit the bone or hit the top of the bone, and fluids were coming out. You guys got to make sure that you're watching to make sure that it is where it's supposed to, that we don't have any fluids coming around and infiltrating the area. Head of the humerus, obviously we're going to use the yellow catheter. Don't forget to go ahead and put the wristband that comes with it on the patient, on the extremity where the IO actually is.
You should also tell them to check underneath the leg. If they're looking
Yes.
for infiltration, if you go through the bone.
If you go through the bone, you're going to have it. Yeah, you got to make sure you're checking for any infiltration. Yes, very good point to check on both sides. Adults, we use 5 to 10 mLs is for a flush. Children, 2 to 5. What is our bottom weight that we can use for an IO needle? 3 kilos, yeah, 3 kilos. And if we look at newborn babies, unless they're a preemie, there was something wrong, most babies are at least 5 or 6 pounds when they're born. So we would be able to go ahead and use the IO for them. Do you guys even carry the old Cook needles or the blue ones? Yeah, the barbaric ones. Gonna need a pressure bag. Do you guys use blood pressure cuffs or pressure bags?
Blood pressure cuffs.
Okay.
Either one of them.
Either one, it depends on what you have, right? Yeah. Pressure cuffs are nice, but you, just like that with the blood pressure, you have to make sure that you're checking them and you're keeping the proper pressure. So, I know our protocol states, there we go. I know our protocol states the indications for doing this. Someone's in shock, impending arrest, you've attempted twice, or you've looked for 90 seconds. I'm hoping we're changing those, and I think there was talk about it. I mean, obviously, cardiac arrest, it's just easiest to go straight to the IO. You've got someone who's critical. We don't want you wasting time trying to find an IV site for 90 seconds if there's nothing there. Just go straight to the IO. We can use them on patients who are critical, that are still conscious or somewhat conscious. To be honest with you, this hurts no more than probably a 14 gauge needle in the back of the hand, which is pretty painful, but what really is painful is the fluids going on. So we would administer pain management to anybody that had this done. And we're going to use lidocaine, 50 milligrams of lidocaine for the adult. You're going to slowly push in the lidocaine. You're going to do that over 60 seconds. And then you're going to wait 60 seconds. Otherwise, it's like you go into the dentist to have a cavity filled. Doctor numbs you up with the lidocaine and says, okay, I'm going to start drilling right away. No, he usually walks out of the room for a little bit, makes sure that it gets a chance to become numb before he goes ahead and starts drilling. And it's the same thing with this. You want to at least give the lidocaine an opportunity to start numbing the area before you introduce fluids. If the patient is still complaining of a lot of pain after you've done that and you've been running fluids, you can administer another 50 milligrams of lidocaine, but again over 60 seconds, and then wait another 60 seconds. Pediatrics, same indications, contraindications, everything, but we're going to use 1 milligram per kilo with a max of 50 for them. Okay. And like I said, our max dose, or not our max dose, our bottom weight is 3 kilos. Anybody questions on those? All right, needle decompressions. Do you guys have a special needle decompression kit made up, or do you just pull a needle out of 14 gauge out of your IV catheter bin? Yeah, really need the kit. Most of us don't carry the 3-inch IV catheters on our ambulances, and that's what you really need. Most of the IV catheters that we're using, the inch, inch and a half, are not long enough to do the needle decompression. So we want an IV catheter. We're no longer using the tip of our glove as a flapper valve anymore. Okay, so don't do that anymore. Make sure we're cleaning the spot. We're going to find the second and third intercostal space. Remember, the first rib is pretty much right underneath the clavicle, so make sure you're counting appropriately. We use the mid-clavicular line, and we're going to go above the needle. We stay away from below. There's too many blood vessels and too many nerves below that rib that can cause problems. I've done a couple of them. I've never ever heard a whoosh. Everybody talks about, listen for the whoosh. I've never heard a whoosh, but you have, that's great. You're going to go ahead and insert the catheter over the top of the rib, pull out your the needle, and then secure it. You can secure it with tape. Now, if your patient starts to develop an additional pneumo, you can go either to the right or to the left. Depends on which side it is. If it was on the left side, I'm probably going to go laterally to the one, and then you can go ahead and insert another one if necessary. Anybody have any questions on needle decompressions?